Okay, welcome everyone to the virtual Compassion in Action Healthcare Conference. I am Melissa Restivo, Event and Sponsorship Manager at the Schwartz Center for Compassionate Healthcare. On behalf of all of us from the Schwartz Center, we are so happy that you've joined us for today's panel discussion, Caring and Advocating for Immigrant Patients in the Current Political Climate. Before we begin, I wanted to remind our audience to share their chat messages and questions for our panelists with everyone in an effort to build community in this virtual space. Now, please join me in welcoming our speakers for this session. Our moderator for today will be Altaf Sadi. Altaf is a neurologist at Massachusetts General Hospital and an instructor of neurology at Harvard Medical School. Joining Altaf are our panelists. Chanel Diaz is an instructor of medicine at Montefiore Medical Center and Albert Einstein College of Medicine. And Mark Kashevsky is a professor of medical ethics at Loyola University Chicago Stritch School of Medicine. Thank you all so much for joining us today. Altaf, I'll turn it over to you.
Thank you so much, Melissa, and for everyone for joining us today. I am going to make my own job a little bit easier by having both Chanel and Mark give a little bit more information about themselves when they begin their talks. In terms of my own role, I should add that in addition, I am the Associate Director of the MGH Asylum Clinic, so at Massachusetts General Hospital where I work. And I've also been a medical expert with the Physicians for Human Rights Asylum Network. And when we started thinking about this workshop and this webinar, there had been a lot fewer anti-immigrant policies in place. Now, in October 2020, we are giving this webinar at the heels of the most recent tragic news in the migrant health space, which is that 545 children still remain separated from their children. Another recent Migration Policy Institute report that was released earlier this summer documented that there were over 400 different immigration-related executive actions that have taken place under the Trump administration. So I just wanted to mention that because this is a space that has really impacted our patients over the past 4 years. There have been over 400 different immigration policies that have impacted our patients. And we really hope that you leave this webinar with some practical and pragmatic skills to take back to caring for your immigrant patients. So I'm not going to speak anymore until the end, but I will share my screen and sort of begin. And while I do that, Mark, you can introduce yourself.
Yes, thank you so much, Altaf, for having me as part of this panel. As you heard, I am a professor of medical ethics at Loyola in Chicago at the medical school. I am not a physician. I'm a PhD bioethicist. But as a clinical ethics consultant, often people call physicians and nurses can call clinical ethics consults when there's a difficult problem in the clinical setting. I've been interested in the plight of undocumented immigrants for more than 2 decades, right, with issues that arose in the clinic, often somebody being in the hospital, perhaps uninsured, unable to be transferred to rehab care or things like that, and they would call an ethics consult. And that's how I first got interested in these issues and really the injustice that was foisted upon undocumented immigrant patients, hardworking, contributing members of our community, but then who normally didn't need much in the way of health care because they were younger and healthier, but things like accidents and so on would cause them to come in. And so this plight attracted my attention, and I began to work on these issues. And then when DACA was created, I started to work in my medical school to open a doorway to undocumented students who wanted to become physicians. And we've now have 24 of our alumni who are DACA recipients go into residency. We have 18 DACA medical students. And if we can have that first slide, the next slide. Next slide, please. With Johanna Mejia Speck, whom you see listed on there, we created some materials called the Sanctuary Doctoring Materials. And these are materials to help people in the clinic, particularly we have primary care clinics in mind, but they're useful in any clinic, to address the concerns of undocumented patients who might be coming to stresses, because as Althoff said, particularly in the last 4 years, the level of stress in the communities has been really ratcheted up dramatically, and this can have health implications. So we have a website, and you can see the address of it up there, luc.edu/sanctuary doctor. It takes you to an open access article that details the materials we've created to help you address these issues in the clinic. In particular, I'm going to talk a lot about the flyer templates, and they're templates, meaning you can download them and amend them to your particular clinical needs. There's some button artwork you can download, and also we have a demonstration video of a sample conversation, but of course, again, adapting it to the way you would approach a patient. But notice the cover of the Sanctuary Doctor flyer. It's headed Immigration Status and Your Health. And you see right below that it says immigration problems can impact your health or the health of a family member or neighbor. Your doctor and the clinic team can help. The doctor's office is a safe place to discuss your concerns and find resources. If you'd like to talk to your doctor or any of us here at and this is our Access to Care clinic, our safety net clinic, about immigration related problems, just hand this brochure to the doctor or any of the staff. And so the idea is the brochure being out in the clinic office can help open the conversation. And interestingly, perhaps our key finding over the few years we've deployed this is that if these flyers sit out in the public waiting area, they can stay there until they actually decay. If you put them in the exam rooms, they fly off the shelves, because when patients are free to take them in the privacy of an exam room, they really want this information, but they're very nervous about claiming something like this in front of somebody else. Next slide, please. The objectives of the Sanctuary Doctoring Program are to open a dialogue, and we just gave one way that might happen with the flyer, but I'm going to focus really on providing reassurance and providing resources to these patients. That's what you'll be able to do in your clinic in a very short amount of time, in under 10 minutes, and the flyers will help you with those resources. We also suggest beginning to develop an emergency plan, but that's very hard to do in any detailed clinic setting. We'll just really make one suggestion along those lines, namely updating the child's emergency contacts at their school. Assuming your patient is an adult, we think that one way to reassure them that their child will be okay is to make sure the right people will pick that child up should anything happen, the worst case scenario of being detained. Next slide, please. Providing reassurance. We have a couple of suggestions along these lines. One is just to make sure that they know they're not alone. Anytime you have a problem in life, no matter what it is, and being undocumented is no different. You fear you're the only person who's got this problem. You're the one in trouble. You feel alone. Help them know that many people, many of your patients are going through similar struggles. Tell them they're not alone. You're with them on this journey. And of course, the reason you're talking about this, because they're going to still probably be wondering, should I be talking to my doctor about this? This impacts their health. Let them know that's why you're talking to them. And you want to help make sure that it doesn't impact their health adversely. And the other piece of reassurance is confidentiality. Tell them you will not write in the medical record anything about their immigration status. You're going to have to find ways to work around that. You might have to write things like they're not eligible for Medicaid or any other program, something like that. That's going to be kind of code to you, but they don't know what happens to the medical record. They don't. If they see you sitting at the computer typing in their immigration status, it's game over. And so we have to reassure them that you will not record that information, and keep going back to reassuring them that they're not alone. This is not unusual. Next slide, please. And this is the inside of the brochure. And again, this does that reassurance and paper the same way we're suggesting that you do it verbally. It basically tells them you don't have to talk about this, but everybody here pledges to be as helpful to you as possible in assisting you if you're suffering from the stress and health problems caused by anxieties related to immigration status. If you're suffering from such stressors, you can discuss them with us. We've taken the pledge. And notice this pledge. We here at the Access to Care Clinic pledge to listen to you, express the ways these problems related to immigration are adversely affecting you, not record your immigration status in any medical records, work to find ways to reduce that stress that's causing problems it's causing you, your family, or community, and to refer you to resources. And that's the other thing we want to make sure they get are some resources to help them to assist with social or legal support. Next slide, please. The resources in the sanctuary doctrine flyer are really of two kinds. As you see B there, there's some legal resources that you can refer them to. And again, the flyer is going to be adjustable. There's national resources that we have in the template, but we want you to get on Google and find some local resources, legal resources as well, and then put them into the template, alter it to fit the needs of your community. Also, there are resources for undocumented youth to connect with networks, because undocumented youth can be isolated in two ways. One, they may not be able to keep up with new information. A lot's been happening around DACA. As many of you know, there was a recent Supreme Court decision. There had been so much going on when it was first rescinded in 2017, and then everybody thought it was over. Then it was kept open by court order, and then it went to the Supreme Court, and young people didn't know what was going on all the time. But there are they're also called Dreamer networks, like United We Dream and other networks of national networks. So get that information out to them so they know what's going on, so they know things like when they should renew their work permits if they have DACA. And also, there are undocumented youth are ineligible for any scholarship resources from the federal government or federal student loans, but there are many private scholarships available that regardless of immigration status. And so they need to be able to navigate those opportunities to continue their educational path. And those are the kinds of resources we want to put in the brochure. Next slide, please. And you can see the legal resources here, Know Your Rights training available on the ACU website. And the National Immigration Justice Center, and then there's some local attorney services. And again, you could find these in a place in your community simply by getting on Google and putting in keywords like immigrants, legal resources, and finding out who's available in your community centers. Of course, many people like social workers in your facilities may know about them, but the idea is to adjust this template to make sure it's as useful as possible. Next slide, please. And here you see for the undocumented youth, there's social and educational information, and you can see United We Dream, and then scholarship resources, and a variety of, then we put in some local resources. Diversity and multicultural affairs offices at universities often have many resources and scholarship lists and can refer them to other Dreamer organizations. Next slide, please. And again, we're not going to take you very far down the path of emergency contacts, but recommend they use the Know Their Rights training. Or as we saw in the brochure, it has the link to the ACLU's site. And a simple thing like knowing that you don't have to open your front door if ICE is knocking at it can often protect somebody very well. And that's the kind of information we want to get across to them. And again, the other piece we recommend, while it seems anxiety-provoking to talk about a worst-case scenario, such as if they are detained, it's on their mind already. So suggesting to them that they make sure emergency contacts are updated at school so that their child doesn't go to foster care, but goes to a family member or somebody they really trust who can pick them up. Next slide, please. And finally, I think one of the reasons many people don't go down this road, many healthcare providers, is because they feel like, okay, I'm going to open a can of worms and I'm not going to know how to follow up. I'm not really well connected in this area. Much like, we don't say a few words of Spanish to a Spanish-speaking patient because we're afraid they're going to start talking to us in Spanish and we won't know what to do, right? And so, but the fact of the matter is, you can find out an awful lot very easily. You probably in your local area have professional societies that are involved in this. There are immigrant advocacy organizations, there are lawyers networks. But you can find out an awful lot about this simply by using Google. Now, I know with the antitrust suit going on, I probably should be saying search engine instead of Google, but you're probably using Google. By just Googling resources in your area for immigrants, you can find an awful lot. I've done workshops with providers in various communities, and they're stunned. This is what we do. We sit down, we open a search engine, and we start looking for resources, and we start sharing them. And really, in an hour, you'd be surprised you can alter this template to really meet the needs of your patients. And it might be the best hour you've ever invested. So thank you very much.
Thank you, Mark. This is great to hear. So I'm going to transition to talk about the role of health workers in exposing human rights abuses in immigration jails. So some of the downstream effects of these harsh and racist immigration policies. So I'm going to give a brief overview of the scope of immigration detention in the United States, and then describe the health harms that are associated with it, the current public health crisis, and end with the really unique role that healthcare workers can play in this moment. Next slide. So I'd like to clarify some terminology before I get into it, because I think accuracy matters in the current discourse. So immigration detention refers to the practice of incarcerating human beings while they await for a judge to decide their immigration case. Although they're confined, people in immigration detention are not charged with criminal violations. And in the US context, most facilities are either county jails that contract with Immigration and Customs Enforcement Agency, which are all hereby referred to as ICE, or prisons run by private for-profit companies, including the Geo Group, Pure Civic, LaSalle. So I'll be referring to them broadly as immigration jails for that reason. I will also avoid using the term detainee, which is dehumanizing language. So this picture is a depiction of our mass incarceration and detention system. We know that the US is the world's largest incarcerator with over 2 million people in prisons and jails across the country. And this photo really illustrates the ways in which this system of mass incarceration, which is fueled by racist policies, also drives the detention and deportation machine. It really feels like this is a machine that is churning people through it. In that context, the Department of Homeland Security operates the largest immigration detention system in the world and spends more on immigration enforcement than all other federal criminal law enforcement agencies combined. In 2018, that was $7.4 billion spent on immigration detention. Next slide. There's been an exponential increase in the number of individuals held in immigration detention on any given day, in part driven by the for-profit motive, laws passed in 1996, the post 9/11 special interest roundup, the creation of ICE, which happened circa 2002-2003, and a detention bed mandate that was actually set by Congress in 2010 that requires ICE to maintain a minimum of 34,000 beds. So pre the COVID-19 pandemic, there were at least 50,000 people on any given day in over 200 immigration jails and prisons across the country. 70% of those people were detained in private or profit jails. Next slide. Next slide. So it's important to note that media reports of high-profile deaths are only the tip of the iceberg when it comes to the gross medical negligence and human rights violations occurring in immigration jails. While there have been 50 deaths in ICE custody since 2017, that number does not include individuals who died in Customs and Border Protection custody, such as the high-profile deaths of children, including Jacqueline and Felipe. And it also does not include people who were hospitalized while detained, but technically released from ICE custody immediately preceding their death. And I think at this point, I'm realizing that I didn't really explain my interest in this topic. So I'll just pause for a moment to kind of give context. I'm an internist, also trained in public health. I work in the South Bronx at Montefiore Medical Center. And during medical school, I was involved in asylum evaluations through Physicians for Human Rights. That work continued in residency, but I started to work with individuals who were actually detained in immigration jails in New York and New Jersey in particular. And it was really when I started to do evaluations in these immigration jails that I started to realize just the scope of the problem and the role that healthcare workers could play. And so some of the upcoming information is really coming from a personal perspective of being involved in this work. Next slide. Under the US Constitution and international law, anyone who is detained or incarcerated is entitled to adequate medical care. And several reports that are highlighted on the slide have documented clear-cut instances of severely substandard medical care that had led to significant suffering and at times preventable deaths in detention. They've consistently found across the board systemic failures, such as over-reliance on unqualified medical staff, chronic delays in emergency responses, and unreasonable delays after requests for medical care are put in. And I will quote Claire Long of Human Rights Watch. These death reviews show that system-wide problems remain, including a failure to prevent or fix substandard medical care that literally kills people. Next slide. Next one. Thank you. And the COVID-19 pandemic has really shed a light on the public health hazards that are inherent to the current system of immigration detention. There's actually a QR code that you can scan, and it'll link to an op-ed that specifically speaks to this issue. But generally speaking, the conditions in confinement are characterized by overcrowding, poor sanitation, lack of hygiene, where basic necessities such as soap and hand sanitizer are not routinely provided, as well as low immunization rates, poor nutrition, and as you can imagine, toxic stress levels. So these are the perfect recipe for disease outbreaks, and there have been several over the years. Worst being the COVID-19 pandemic. Thus far, ICE has reported 6,755 confirmed COVID-19 cases among people detained, and there have been 8 confirmed deaths related to COVID-19. I say confirmed because advocates and people in detention have signaled that this is a gross underestimate, that many individuals with symptoms are not being isolated, not being tested, and that there isn't widespread routine testing to really know the true scope of the problem. There have also been reports of the misuse of solitary confinement for sick individuals, toxic exposures to chemical disinfectants, and retaliation against individuals who speak out against what is happening. Next slide. The Medical Providers Network that I'm a part of was actually formed around 2016 by the New York Lawyers for the Public Interest and arose out of a need for advocacy on behalf of individuals with serious medical conditions whose health was deteriorating in immigration jails. And this is a community medical legal partnership that connects immigration lawyers and community advocates to volunteer medical providers. The medical providers review medical records, evaluate individuals in detention, and then we educate the legal team about the medical needs identified and further the judge's understanding of their illness and the case. We write medical affidavits or advocacy letters that are then used by the lawyers or community advocates to argue for the person's release from detention and their access to necessary medical care. And this is just one example of many similar networks that exist across the country. Next slide. So health workers have a really important role to as healthcare workers, we have a really important role to play in bearing witness. And so volunteers have documented instances of denial of vital medical treatments, such as dialysis, access to insulin, dangerous delays in medical attention, missing diagnoses that require urgent surgical attention, like appendicitis, failures to meet basic standards of care, and conditions, as I described previously, that can lead to infectious disease outbreaks, as well as human rights abuses, including the use of solitary confinement, either for retaliation or as a response to mental health crises, which we know is not the answer. I've witnessed how detention intentionally strips people of their humanity. And everyone that I've spoken to who was detained has told me that they feel like they are treated like animals in the current system. They're not seen as human beings who have rights. And when that's the standard, you can imagine what that does to someone's health, both physical and mental. Next slide. as healthcare workers, we have an important role to play because in some instances, we are given access to otherwise closed facilities that advocates cannot even go into. We're also given time without limitation to speak with someone and visit with someone. And we're allowed to bear witness in a way that others may not be. More importantly though, as healthcare workers, we can document and speak to how the medical neglect is a systemic feature of immigration jails. And these partnerships with legal and community advocates have direct impacts on individual cases, but they also have broader implications for holding the government accountable, whether it's publicly or via litigation. Next slide. And I think it's really important to think about, in the face of these sustained attacks on immigrants that have escalated in years and months, bearing witness feels inadequate. I think that we're at a point, and have been, where we're called to take action to protect human rights and lives. And these photos and clippings are examples of actions that health workers have taken, of ways in which they've spoken up, shed a light on what's happening, and really demanded that we do better. And I would end by saying that a humane immigration system would actually seek to limit the scope of detention, and especially for vulnerable groups, and to really increase in community-based alternatives to detention, implementing trauma-informed standards of care and accountability measures, which are not existent today. We very clearly stated that it was essential to free everyone who's detained, especially in this moment, to stop the spread of COVID-19. And I'll end there.
Thank you so much, Chanel. I'm going to end off with sharing a little bit about my work in this space as well. But before I do, wanted to encourage everyone to use the chat box for thoughts, sharing resources, questions, as well as the Q&A. We'll take a look at both and make sure people's questions are answered, as well as just sort of general conversation topics that people want to talk about. So I'm going to be circling back to the fear that people live in the community, which centers around fear of immigration enforcement that could potentially lead to detention and deportation. So you may all be familiar with the story of Rosa Hernandez, who is a 10-year-old girl with cerebral palsy, undocumented, and was taken to the hospital needing gallbladder surgery. But because she crossed a checkpoint, and this was in Texas, she was intercepted and arrested by Customs and Border Protection. Because of advocacy on part of physicians and other clinicians and sort of everyone, she was eventually released. But her case was not one that stood out alone. Just last month, this is a 15-year-old girl who had lived in the US since she was an infant, and similarly was in Texas, was with her aunt, and was going to the hospital for gallbladder related pain. And the local hospital she went to said that she would need surgery. So they said that she had to go to San Antonio, to a hospital there. And the same thing happened. She was being transported, had to travel through a checkpoint on way to San Antonio, and was arrested. So when Rosa Hernandez's case happened, many of us, there's a lot of outcry saying that even this one case was one too many, because that was enough to induce fear and uncertainty in people in terms of seeking healthcare. But sadly, hers was not the only case, and there have been so many thereafter, including this one that just happened a month ago. And I just want to point out that this is something that in any other context would have made much bigger headlines, but so much has happened just even in the past month that this has sort of been a little blip and people have moved on, right? The immigration space is so constantly changing, and there's been sort of an onslaught of activities and policies that have affected this community. Although this is from a survey we did with the Physicians for Human Rights Asylum Network, and here on the left, you'll see that actually less than 10% of the clinicians, this was about 250 who filled out the survey, reported witnessing immigration and enforcement at their work. Even that is, I think, too many times, but I think here I just sort of wanted to point out that even though that might be happening very few times, right, there's still the fear is there. So here, at least half in our sample reported that their immigrant patients were reporting increased fear of immigration enforcement at or near healthcare facilities. 40% of the clinicians who filled out the survey reporting decreased use of health services, nearly 20% having observed negative effects of immigration enforcement on the health of their patients. So again, this only needs to happen a handful of times for it to have an effect, because that fear is contagious and it sort of spreads across communities. This is a quote that I wanted to read from the survey, and I'm going to read it because I think it is really poignant. But this physician who filled out the survey says, "I have seen a significant increase in no-show rates and clinic cancellations, particularly among my Latino patients. I've had more patients than I can count tell me that they fear for their parents' or relatives' safety, which has contributed to adverse mental health effects. For example, a 13-year-old patient with new panic attacks after her father was forcibly removed from the home by ICE. A 17-year-old with a suicide attempt after the deportation of his mother. There are too many to count. I've also had patients refuse hospitalizations due to concerns that immigration enforcement will be present, which has led to managing serious illnesses on an outpatient basis." So we know that this is affecting health, and this sort of fits within a large body of literature that is documented over and over again that immigration enforcement and increased anti-immigrant rhetoric affects physical and mental health, including preterm births, including worsening cardiovascular disease risk factors. And so I was interested in thinking about, okay, well, maybe at the federal level, there's advocacy being done there, but what could be done within the walls of our institutions, of the hospitals that we work for? And so I conducted a multi-state study across 5 states that have the largest undocumented immigrant populations, and to see what healthcare facilities were doing to address the fears in immigrant communities. So I'm actually we have, in addition to sort of the academic work, have released a toolkit and YouTube videos that go through some of these strategies, and I'm just going to show you the introductory video.
Hi there, I'm Dr. Altaf Sadi. I'm a doctor and researcher passionate about immigrant health. For the past 2 years, I've been researching and documenting the relationship between the needs of immigrant patients and what clinicians and institutions can do to meet those needs. Immigrants have been under attack since the 2016 presidential election and its aftermath. During this time, clinicians and health systems across the country started noticing immigrant patients were changing how they access healthcare. On one hand, not showing up to visits or being afraid that accessing care could jeopardize them in some way. On the other, coming in with more anxiety and mental health issues from their increased worries. So healthcare facilities and clinicians began implementing new policies and programs because their goal is to care about your health, not your immigration status. For my research, I became interested in understanding what specifically these new policies and programs were, so that hospitals and clinics nationwide could replicate these same actions with the hope of protecting and welcoming immigrant patients in the healthcare setting.
And I'm going to stop there and sort of jump into what some of these policies could look like. And so there's 13 in total, and they fall within 5 major domains. So one is policies relating to reducing or addressing the risk of immigration enforcement personnel on or near facilities. So that could include implementing a policy that limits cooperation with ICE, designating public and private spaces because immigration enforcement cannot enter private spaces without a warrant signed by a judge. There's a set of policies that address the risk of immigration status related information disclosure. So this is something that Mark brought up, but can become sort of a hospital disseminated policy, which is like limiting, acquiring, and documenting immigration status in medical records. And then addressing risk related to patient level stressors. So one of those is legal related stressors. And this is something that relates to Chanel's work, which is pursuing medical legal or medical community legal collaborations to meet the legal needs of immigrants, and also includes things like deportation preparedness and incorporating that into larger patient emergency preparedness. And then also thinking about promoting resilience. So that includes, and I've seen this at different clinics, advocacy skills workshops, media and storytelling skill building programs, voter registration drives, really contributing to the sense of empowerment that people feel rather than feeling powerless and out of control in this situation. And then not forgetting about patient providers. So one is mitigating practitioner level stressors. So nationwide, nearly 1 in 5 healthcare workers are immigrants. And we need to think about them as being part of the solution, including providing supportive services for employees who are immigrants. And then lastly is coordinating this risk mitigation. So they're really needing to be a designated point person or task force that's charged with thinking about this constantly evolving and very complex space that's at the intersection of healthcare and immigration policy. To give you, I'm going to show just a section of one of the other videos just to get a bit a sense of what some of these policies would look like in more detail.
Patient level. I found that there were 6 common actions healthcare facilities were taking at the patient level. Here they are in no particular order. 1. Educating patients about legal rights, whether by using community health workers, community-based immigrant organizations, or just having Know Your Rights cards in waiting rooms or clinic exam rooms, the same way there are pamphlets about diabetes or hypertension. 2. Pursuing collaboration with trusted legal partners, whether through a formal medical legal partnership, which is having a lawyer embedded in the healthcare team to refer patients to who have legal immigration issues, or increasing access to them through resource fairs or resource guides. Many immigrants can get caught up in fraudulent legal schemes, so knowing trusted local legal sources is very helpful. 3. Promoting affirming care messages to express to all patients that they are welcome. Best practices depend on the local context, like whether this should take the form of a poster or be disseminated using social media, radio, or television advertisements. Using sanctuary language can be ambiguous and falsely reassuring, or have different meanings in other languages. So steering clear of this language avoids confusion or providing false reassurance. 4. Incorporating deportation preparedness into larger emergency preparedness planning.
I'm actually going to stop it there because that's something that Mark also talked about in his presentation. But I encourage you to check out our website, Doctors for Immigrants, that includes a toolkit with resources as well as videos for your viewing pleasure. But I think one of the concepts that I have been, and a lot of my colleagues have been trying to push is that, I think a lot of us are familiar with trauma-informed care, and which includes principles like safety, transparency, empowerment. And we're trying to say, well, to build on top of that, we could adopt the concept of immigration-informed care. So what are additional things that would need to be put into place specifically to meet the needs of immigrant patients? So that would include language services, clearly delineated referral pathways for undocumented patients, culturally competent clinicians who are trained to discuss sensitive topics without inciting fear, the way Mark so beautifully laid out in his presentation, and then as well as institutional policies that ensure the physical and psychological safety of immigrant patients, like we talked about. And so I think with that, we're going to end and try to have a conversation about these issues. I don't see any right now in the chat or the Q&A, so I'm going to start off by asking Mark about his experience. I know one of the things you mentioned was that you found when you put the pamphlets in the waiting rooms, they were not as effective as putting them in exam rooms. Are there sort of other lessons that you think that you have learned along the way in terms of things that didn't work out as well initially?
Well, thanks for that question. The single hardest thing is starting the conversation, getting the conversation opened, because, obviously it's very easy to scare the patient, because just raising immigration status is terrifying. And so providers, are obviously very reluctant to do that. And so the brochure is one way, but truth be told, we've given out a couple thousand brochures at multiple facilities, and we've only got reports of a handful of the conversations where people use it to open the conversation. Otherwise, what we hear reports of is that it opens kind of spontaneously, and we haven't found a systematic way to do this. Johanna Mejias-Beck, Dr. Mejias-Beck, who helped co-design this, talks about just learning to pick up on cues that, talking to a teenage patient who she asks her, okay, so you're 16, are you starting to learn to drive? And noticing the person looking down and not wanting to answer the question. And she realized immediately what was happening, and just put her hands on the patient's hands, and the patient started to cry and then started to talk about the stress of being undocumented, not being able to go for a license. So the genie that we can't figure out how to get into a bottle that we can distribute is that conversation opener. That's the hardest part.
I think you bring up a really good point, because at some of the health centers that I visited, there had been concerns raised in some departments where these conversations had gone poorly, right? That sometimes you could bring it up, and if you are not bringing it up in a way that's sensitive, you can actually make people more worried or be like, why is this person asking me? And there's a lot of fear about information sharing, right, between institutions. And so it's sort of the element of not just making sure that that's talked about, but that if you do talk about it, it needs to be done in a way that's not contributing to fears more.
Yes.
Yeah. I see a question here that asks, do you feel personal burnout as you hear these stories and difficulties families, individuals are dealing with, and how are you caring for yourself to be as compassionate and present as possible? Chanel, do you want to start, and then Mark, and then I can go.
Sure. I think there's no doubt that it's really hard, and I think that there is a degree of vicarious trauma that happens, especially with doing asylum evaluations or some of the detention evaluations, but even in the clinic. And I think that personally, especially the detention evaluations have been empowering to some degree, because I see the immediate results. I know when someone is released as a result of the collaboration with the legal team, with advocates. And so it's been my way of fighting against this moral injury, has been just kind of like doing what I feel that I can in the moment. But it's hard because it does feel very daunting at times. And it's like every day it's like, okay, what is the newest form of harm that is being implemented?
Yeah, and I want to be very humble in my response to this, because I don't deal with this on a day-to-day level of a physician who is doing lots of exams or doing asylum examinations with some frequency or things like that. And so I do think there's a different level of stress and care that needs to go on for physicians and other clinicians who are in those situations. For me, these things tend to be more sporadic because, I'm kind of known as a resource, and so people will come to me with different issues, and I have to help them try to see their way through it. And the main, I think, challenge for me all the time psychologically is always, when am I doing everything I can be doing, and when am I trying to push beyond what actually can be done here? And a lot of that is because our role is to accompany people. It is ultimately not our lives that are on the line. It is, not our, when a student has a parent in deportation proceedings, that is not my parent, that is not my family. And I also have to respect their space and the decisions they make, and so which are sometimes different than the ones I would advise to make in terms of bringing attention to the situation, and various kinds of advocacy that are possible. And sometimes a parent will say to the child, when the parent's in deportation proceedings, enough is enough. Go on with your life. This is I didn't come here for everything to be about my staying here, and they don't want to take the focus off. In those moments, it's brutally hard because we want to fight more and fight to the end, but yet it is their family. They're the ones who made that decision to try to advance their families' well-being in the ways they have, and we have to respect that. And so I find myself, that the old serenity prayer, or to change the things I can and to accept the things I cannot change. And a lot of there can be nights where you lay awake at night trying to wonder where the line is between those. But again, I say this humbly because my work does not take me into this on a day-to-day basis with the intensity of people doing examinations on patients in proceedings or in custody.
Thank you so much, Mark. I think your point about sort of accepting people's decisions and the serenity prayer is really poignant. Having sort of doing the asylum work and the detention work, certainly, I think as Chanel said, the vicarious trauma is there. I remember after I was a medical expert for a report with Disability Rights California, which involved doing 15 evaluations over a span of 2 days, sort of back to back in detention, and I was, there the entire day. And I had nightmares for a good 2-3 weeks afterwards. Like, I could not sleep. I would wake up with nightmares of the stories. I even just sort of reading news articles would be like, has this person died? Is this someone that I did an evaluation for? Is this someone that I met in the course of the work that I did? And I had to take a break from my sort of mental well-being for a bit, because it was just really hard to do so many sort of back to back. And so now I'm a lot more mindful about sort of spacing it out, and also being much more mindful about having regular conversations with my peers where I can debrief and talk about these difficult cases, because it is really hard to hold on to these stories, and stories that people have shared that they rarely get to share with someone else. I remember one person in detention who had been there for 2 years, and I had talked to him for an hour, and he just said in the end, and we were talking about his experience in solitary confinement, so it wasn't really that interesting of a conversation, but he said, Doc, that you are the person I've talked with the longest period of time over the past 2 years. And it just really struck me that someone is sort of in detention and the longest conversation they had was with me. So I say that, and then I also want to sort of share in this from our Physicians for Human Rights Asylum Network survey, was that, so again, I think it was about 250 who filled it out, and about 60% reported vicarious trauma. And then 90% reported vicarious resilience. So people saying that they actually felt a sense of personal growth and personal resilience, looking at their life differently because of the work that they were doing. And that's something that's really stuck with me, and something, we're working on writing this paper up, but I just want to share with this group because there is that concept of vicarious resilience that lives hand in hand. And it is really such a privilege to do this work. Let me just look through some of the other conversation or the other comments. Yeah, and thank you all for sort of these comments.
Alta, if I could just mention this one comment about the importance of policies that's mentioned, which I think is very true. But the one challenge I think that we all face is that policies for what we call front door policies that Altaf talked about, when ICE comes to the front door, we try to keep them in the public space and ask for a warrant. We can get those created and we initially implement them. It is a challenge for us to upkeep them and keep people in the know who need to be in the know, because as the data you presented, Altaf, showed, most people don't see an ICE agent in the front door of their facility very often. So I always compare them to say something as dreadful as active shooter policies. That you're very unlikely to see an active shooter, but if you do, everybody really needs to know what to do at that very moment. And so, but maintaining that sense of vigilance and awareness is a constant challenge for all of us, I think.
Yeah, I think one of the strategies that I have seen sort of be successful at some institutions that I traveled around that policy in particular was really linking it to law enforcement more broadly. And I think that's probably something that now is being hopefully more talked about in the context of sort of racial justice. And, just this past month, there was a shooting in Harbor, UCLA, of a police having shot a patient in the hospital. And so I think that success, I have seen success in places where they've sort of linked the two together and say, like, look, law enforcement shows up more often than immigration enforcement. So this is something that we can upkeep, but let's make sure that it's part of the conversation.
Excellent point.
And I think that one aspect that's really important, and I think it kind of speaks to the resiliency piece too, is partnership with community advocates, with people who are directly impacted by these policies. And I think that even just thinking about how to make these policies have the biggest impact, how to make it so that communities know they exist, and then how to hold our healthcare institutions accountable to the communities that we serve, that piece of collaboration and working with community is really essential to that.
Thanks for Sean, your comment sort of, and maybe relates to the previous comment about these policies, is one of the things that, and so actually one of the things that had come up, and when I talk to folks that they're talking about wanting to institute this, sometimes I think, look, and I talk to them, maybe, the likelihood of this happening where in your city is so low that maybe better time is going to be spent setting up a medical legal partnership or a medical legal community partnership where you can address patients' legal needs. And if you are able to switch someone's status from being undocumented and they gain asylum or they gain visa, like that is going to have this lifetime trajectory. And so part of it is sort of strategizing when I speak with folks of like, okay, what is going to be the highest impact where you are? And is that going to be, setting up this policy in a city that might have sanctuary policy laws already in place, and so may not be sort of the highest yield, but then trying to invest in sort of a medical legal partnership, which might sort of actually have more impact on patients' lives. But I think that, yes, so, to your point.
And I think that's even more important now, with the policy landscape, but in particular with the public charge rule. And so the public charge rule has really created this chilling effect across clinics. And so, we're seeing patients disenroll from benefits that they would qualify for. We're seeing this with mixed status families, and so just the misunderstanding of the implications of it, and the fear. Having that medical legal partnership is really helpful to be able to say, like, here is a legal advocate that you can speak to that can kind of reassure you that it's okay to sign up for these benefits, or that it's not in your best interest to sign up for these benefits right now.
We had a question about the resource documents being accessible, and they are. And I, in the Q&A, shared both my website and Mark's toolkit. We'll put that in the chat box as well.
Yeah, and anything from the Sanctuary Doctoring website, like the brochures, you'll see that there's the original template, and then there's multiple adaptations that health systems have used to brand it with their own brand and their own resources, and you could use those as models. And please feel free to make any use of it, and we love to see it if you want to share it back with us, but there's no requirement to. Nothing there is copyrighted. Just take and use as you can.
Great. Well, Altaf, Chanel, Mark, thank you so much. This was such an important discussion, and we really appreciate you sharing your experiences with us. We would also like to thank our national business members. We are so grateful for your support. We wouldn't be able to have this conference without you. And a special thank you to our audience for attending today's session. Please keep an eye out for the recap of this week's sessions and an email containing a link to claim your continuing education credits for today. We look forward to having you all back again on Tuesday, October 27th for Using Recovery Coaching to Provide Culturally Sensitive Substance Use Disorder Care in a Latinx Community in the Time of COVID. A panel discussion with Eula Adeniji, Alita Carroll, Nicole Carr, Eddie Casado, and Windia Rodriguez from Mass General Brigham. I wish you all a good rest of your day and a restful weekend ahead.
Thank you for having us.
Thank you for having us.